further ado, I'm very excited to introduce our first presenter to you today. Many of you have gotten to know Dr. Joseph Shepard and a couple of his colleagues, Dr. Ernesto Matos and Dr. Sora Cayasta, often referred to affectionately as Dr. K. And so they have two clinics, one in the Joplin, Missouri area, one in Neosho, Missouri. And Dr. Shepard, I'm sure, will share some of his story, but it's a little unique how he became a physician. And so he actually was a journalism major when he began his career. And he said, you know what? There's some cool things that maybe some changes that can be made to provide affordable cost health care to everybody, and they can make their own choices. And he said, you know what? Maybe I'll go to med school. Maybe I will do that. And so he'll tell you some of that story today, but it's a 24/7 membership-based access clinic, which means you have 24/7 access to the physicians. He's going to share with that today. So please welcome from Neosho, Missouri, and now Joplin, Missouri, Dr. Joseph Shepard, and free market physician.
I think I'd have JD give the speech for me. He's got a lot of energy, and I think he tells it even better than I do. Am I on the microphone?
Let's see.
What about now? There we go. Okay. Well, thank you for having me out this morning. I'm Joseph Shepard from Free Market Physician Clinic, and I want to tell you a little bit about the story of the clinic, how we got started, what we are, and then ask you a couple questions and get your input on the clinic. So we'll go to the first slide, or next slide.
Oh, your
the clicker
is right up there.
Okay. Okay, so I am an Idaho farm boy. Grew up in southeast Idaho, moving irrigation pipe because it doesn't rain there, so you have to move sprinklers across the field to make it water. I went on a 2-year religious mission in South America after high school. I came back and I went to college and I was a journalism major, and I thought I was going to write. I love to write. I'm a writer. And I was assigned to cover a story in college. In the state of Utah, they were about to make health insurance mandatory for all the university students. And so I was assigned to cover what was a snooze of a story at a time. This was before healthcare reform. And I learned a number of things while I was there. One of the things that I learned is that healthcare plus health insurance costs more than healthcare. And they were saying things like, well, if we get everybody on health insurance, the cost will go down. But as I was talking with industry experts, I was hearing that wasn't the case. And I had some bells going off in my head where I was saying, you know, why don't doctors just charge for their services instead of using health insurance? And I had some kind of neurons starting to fire in my head, making connection. I decided, well, what if I become a cash-only physician? And that kind of kicked off my decision to go to medical school. And so I did go to medical school. I came out to Missouri for medical school. We don't have one in Idaho, just potatoes. And I was developing this idea in medical school. How do you make primary care accessible and affordable for people? And I started writing a medical economics blog. And the blog name was Free Market Physician. And so I was developing these ideas throughout medical school. I went to residency in Springfield at Cox. And about that time, there was a new medical clinic that opened up in Wichita called the Atlas Clinic. And what they'd done is they had taken the concierge model of medicine, where you go to high rollers, to high earners, and you say, oh, pay me $500 a month and I'll be your personal physician. I'll put on plush slippers on your feet when you walk in the room, we'll bring you a latte, and I'll treat you like $1 million. And so they took that model and they said, you know, what if we use that monthly membership model as the funding mechanism for primary care? You know, just cut the health insurance out of the process and make it so that people can just pay a monthly fee and have a doctor. And so they launched the Atlas Clinic, which was revolutionary. You may still hear them now. The founder, Josh Barry, you see him a lot on, Sean Hannity has him on a lot. He ends up on NPR a lot. He ends up on Fox News a lot. And here in the Midwest, anyway, they revolutionized healthcare. And so I went out and I spent a couple weeks at the Atlas Clinic, and I said, this is it. This is what we're going to do. And so we opened the Free Market Physician Clinic in Neosho 7 years ago. So what do? We are physicians who focus on patients and not on health insurance, okay? My feeling is you pay attention and you work for whoever pays you. So if I'm working in an insurance accepting clinic, I'm worried about getting my billing right, getting my coding right, documenting so that I can maximize my billing. And I'm taking care of this patient on the side here too, and I care about the patient, but if I don't take care of the health insurance company, I don't get paid. So what happens if we take them out of the equation? So our patients pay us instead. We're paid a $70 a month fee for adults, $30 a month for children, and we have unlimited office visits, there's no co-pays, and our patients have access to us on nights and weekends by phone, text, and email. We have guaranteed same day and guaranteed on-time appointments. We give a partial refund if we're more than 10 minutes late. And then, oh yeah, I already said that. Our patients have access to us nights and weekends, phone, text, and email. We have labs at wholesale cost and medications at wholesale cost. And the idea is that the predictable part of healthcare, the part that we know that we need, primary healthcare, you pay for it without using health insurance. Insurance is used to pay for unexpected expenses. Why would you use health insurance to pay for what you know you're going to have to pay for? We don't use health insurance to pay for our oil changes, for our gas. We use our health insurance, or we don't use our car insurance to pay for oil changes and gas. We use it to pay for accidents. You know, if you use that health insurance to pay for those other things, the cost of everything would go up, and the same is true in healthcare. So, how does it work? Patients or businesses use us to pay for primary care, and then they'll get some sort of appropriate coverage to pay for the unexpected, some sort of catastrophic or high deductible plan. And the idea is if you use us to pay for your primary care, you get something else to pay for the rest, you pay a whole lot less for the entire package. What do we do in the clinic? We're able to provide preventative care, general care, and urgent care. What we don't do is we don't provide emergency care, specialty care, or hospital care. What we're able to do in the clinic, because we're not catering to health insurance companies, we're able to provide superior customer service. The medical industry is one in which customer service is largely lost. You know, it's hard to find an industry that does worse at customer service than the medical industry, and we're trying to reverse that. We focus on the physician-patient relationship, on getting to know our patients and knowing them well. We know our patients, we know their kids' names, we know their grandkids' names, we know the name of their dog, and when they call us on a night or weekend saying they're having a problem, you better know that we know about their hypertension, their diabetes, their cholesterol issues, and we know what medicines they're on, and can answer your questions for them at 11 o'clock at night. So, I opened my clinic in 2014 in Neosho. I had a full panel by 2017, enough patients to keep me busy and funded. We added a second physician, that's Dr. Ernesto Matos in the middle, in 2018. And then we opened our Joplin clinic with Dr. K, who many of you may know, in 2019. We were really excited, oh boy, this is going to go like gangbusters. September 2019, and then COVID happened. Here is our patient enrollment and our growth. So we grew nicely, and then we have a couple blips. Here is COVID right here, and we kind of flattened out there. And we've had a little bit of growth since then. We've lost a couple of our bigger clients, but that's kind of what it's looked like for us as a business. So what's our biggest challenge as a business? Well, it's patient acquisition. And there's been some challenges that I didn't really anticipate as I thought to grow this business. In my mind, I was going to start a clinic, and then we could just start planning doctors and clinics in southwestern Missouri, and they would grow as well. What I didn't anticipate is I can be a doctor salesman. But there aren't a lot of doctor salesmen out there. You know, there are doctors who love their patients, but do they really want to get out and cold call and go to chamber of commerce events and do all these things? Those people are hard to find, even if they say they are. You know, a lot of them really struggle. I don't have time to market and sell all my new physicians. You know, we need to connect with small businesses, and when we're, especially outside of communities where I live, we've got a challenge. Even Joplin is a little bit of a challenge for me to come up and market up here. We have a rather narrow profit margin. Our goal is to make healthcare personally affordable to anybody that works. If you have a job, you can afford us. And so, yeah, we could really raise our prices, increase that profit margin, have money for advertising costs, but we don't really want to do that either, because if we do so, we kind of lose our purpose and our mission. So our current approach, which is a little bit new for us and seems to be working, we do a lot of network marketing. We've started partnering with local independent insurance agents. We're commissioning them to sell our product. You know, if they've got, you know, all these plans that they sell, you know, they're able to pull us out of the desk if they don't find a good fit for them and say, well, let's look at free market physician clinic. Or in particular, we're working with independent agents to sell small businesses on appropriate insurance plans that couple with us, and save that client a lot of money. We've also started an in-house sales program. We've got Karen Tucker here with us today, who represents us and is selling to the community. And then, of course, we partner with JD, and he's done wonderful things for us in Joplin. If you haven't had a chance to meet JD, he's the ultimate connector. So, how can you help me? You know, of course, if you have anyone that you recommend that we talk with, we would love that. The ideal client for us is a business with under 50 employees. If you have 50 full-time equivalents, you need to have health insurance for them. If you have a group that's less than that, a lot of times these businesses are looking for an affordable benefit to provide people, and those health insurance plans are just not affordable to them. And something like us would work out great. We're a meaningful benefit. We have a business discount over our other rates, and we can take care of their employees for them. We are looking for ways to better connect with small businesses. We're also looking on ways to develop an external sales force. We're hoping not to just do this in Joplin, but do it in other communities. And any other recommendations on patient acquisition as well. So that is what I'd like to put to the group and solicit the wisdom of this crowd here. Thoughts or questions?
Okay, we're going to go ahead and open up for questions. So if you have a question, let's go ahead and open up the forum for a question this time. I'll walk the microphone over to you. Start here. Go ahead.
So if someone has an unexpected emergency, heart issue, something like that, how do you handle that?
Yeah. So we teach all of our patients to have some sort of funding mechanism in place for that. So financially, we're trying to train them to be prepared, whether that be a high deductible plan or a healthcare ministry plan or as a business, a partially self-funded plan, whatever that is. And then we're like any other doctor. We can refer to either hospital system. We work with the specialist. We coordinate the care. We're probably more hands-on than other physicians are. We're rather possessive of our patients, and we try to be very good at coordinating the care. So does that answer your question? Okay, thank you.
Awesome. We have Joe Craig Mile with Mercy.
It's good to see Dr.
Hello.
Shepard. I actually come in, I bring physicians in to meet Dr. Shepard, and I want to attest to what a good group you guys have there.
Appreciate
Very
that.
comfortable feel going in, your new building especially, I really like that.
Oh, thank you.
It just seems to me one of your potential really good targets would be restaurants.
Okay.
Have you approached any restaurant, just because, you know, you could, I mean, for $70 a month, maybe the employer could split it with their employee $35 a piece or something, and make it much more affordable, but most restaurants don't have health insurance, and that's definitely an industry that needs it, so.
That's a great recommendation. I don't think we have a single restaurant that's a client right now. I appreciate that. Thank you very much.
To quickly build on that, actually, and this is one of my questions, is your plans to expand this, because I originally lived in Austin, actually, and on the restaurant note, the single biggest limiting factor for restaurant success in the city of Austin is finding and retaining workers. And there's already significant data that exists around health insurance being a strong retention mechanism for employees that enroll. And so not only can you provide them with that, like you can remove these bottlenecks of employee retention in cities like Austin.
Right, right. And that's, I agree with you 100%. We talk about retention, you know, yeah. The other big thing that we emphasize for employers is reduced time lost, because we guarantee the same day visits. You know, they're able to come in, be seen on time, leave the clinic often with a prescription in hand, and then we'll coordinate with the employers, you know, can they go back to work now, when can they go back, and there's a direct connection there. I like what you say, restaurants. That's a nut we haven't cracked yet.
Well, and I think it's important, because that's my background, was restaurants before I got into my current professions. But, you know, the other thing too is most larger insurances, like health insurance, won't cover restaurants because of the transient nature of the business, right? People come and go. One of the things that I see with the free market side is if it's in direct care, they can take it with them wherever they go.
Yes.
Because they're connected to that. So I think it's a win-win all the way around to be able to offer a benefit in that. Because if you're a large chain, you know, the profit margin there is very small, and they don't want to necessarily pay for it. So if you're living on your tips, most people are paycheck to paycheck in that side of things, or tips to tips. Like, healthcare is not necessarily the thing that they're going, hey, I'm going to spend $200 a month on that. No, that's not the focus. But if they can have something as an option for you, I mean, that's great. I know JD knows quite a few of the restaurant owners in the area and stuff like that, can make connections and,
Yeah.
and probably have that conversation.
Yeah, that's what I was gonna say, how do you connect, and who are the right people in a restaurant to connect with?
The owner.
The owner,
The owner.
right?
So local places connect with the owner.
Yeah, you know, going to a chain.
Right, we're not gonna
most
go to
likely not
McDonald's.
gonna-
Yeah.
That would be a little tougher nut to crack, but yeah, local restaurateurs, and they're usually around, you
Uh-huh.
know, before lunch is typically a good time to go in and see them, or in that afternoon lull between, you know, 2 and 3, somewhere around there.
I also think small business owners that have less than 3 employees, because until you get to that 3 employee group, there's really not a lot of discounted plans for small business owners. And I don't know if that's partnering with, you know, the chamber and asking and say, hey, do you have a list of everybody that, you know, has 1 to 3 employees? Because that's how you register for your fees, right?
Right.
And so, and connecting with them and saying, hey, how do we get coffee? Or maybe we do a workshop with them or something like that, to be able to provide that value. Because there's a lot of, and I'm speaking from personal experience in my business, there's been a period of time where we didn't carry a major medical plan because the cost was more prohibitive
Right.
than to do something like a pre-market physician. If we would have known about that at that time,
Who would be a good fit?
absolutely.
Yeah,
So,
very good. Laurie?
In just hearing this, you know, one of the number one problems with, right now with most of our employers is retention and recruitment of those employees. And maybe even just looking at who's hiring right now and calling them and saying, maybe I can help you offer a better plan to help, instead of you having to raise your hourly wage to, what did I see, Andy's up to
accommodate.
$20 an hour?
Right.
Maybe
Sure.
let me show you how, for a couple, you know, whatever that figures per hour for an employee, how you could offer this and really attract them to your business. So maybe looking at the help wanted ads to see who else hiring, which is a huge list right now.
That's a good
Would be
idea.
a great place to start, because every business that we have is that's their problem. They're not getting people attracting them, and so maybe that's the point that could tip the balance and make them competitive.
Right.
I think one of the cool things happening here is that you see a lot of energy around what you're doing, and that's really exciting. So I just want you to take that in for a second. It's like you've got a room full of people excited about what you're talking about.
Right.
So it's the real deal.
Yeah,
I just want to express that first.
I
And
appreciate that.
secondly, I want to ask, like, what's your vision for your role? Because that's something I'm not sure of. Moving forward, are you wanting to stay a physician, or do you want to be a CEO? Do you want to give this plan away to other people to start their own, or are you wanting to start multiple locations? I think that would help us, you know, get behind you more too, knowing what you want to do in the future.
That's a good question. Right now, I'm kind of letting my own panel fall by attrition. I'm not bringing anybody new in, and over time, you know, people move away, they stop for various reasons. I'd like to keep doing medicine part-time, but I'd really like, at least regionally, to build this system.
Cool.
Yeah.
Yeah, so that requires diminishing returns, which is the hard part, but
Right.
we'll talk more about that, yeah.
Yeah, I bet you've got good advice for me there too. Oh,
Go ahead, Cody.
Two different questions, really. One, what's your enrollment process for a new client? Is it all online? Can you go in, fill out a form, put in a credit card, and you're up and running? Because if you have I think in terms of like ClickFunnels, it sounds really unpersonal, but the ability to actually drive traffic to a path where people self-enroll, once you have that established, you can do some really interesting with Facebook and Instagram marketing, because any life change that triggers an opportunity to have this conversation, whether someone's newly unemployed or whatever, these are targets that you can target in any county, any city, and send them through your path. And then it's a matter of developing a 90-second video that explains your story and see what kind of conversion rate. Because one data point you should be collecting is what your what is the lifetime value of a client. So is the average enrollee in the system for 27 months times $70 equals blank. And then once you know that number, and then you know how much you can spend per new customer acquisition cost, and then he can build a system and quickly, A/B test it and get to profitability. That's kind of a lot there. And then the other question, I'm really interested on how you see communities, how you want to see communities, because that's how you're going to really scale this thing. If you're a physician that's sick of the system, and I was married to one, how do you recruit one, and what do they get? How can you bolt a whole system? How can you build that infrastructure out for somebody that wants to move to or stay in Monette or Lamar? And what is the package that you create, including maybe that funnel to get a new physician going in that community?
Right. And are you asking for an answer to that question?
Yeah.
That's a good question. So, the system that a physician needs to move into, so you need to have the sales process in place, you need to have the system in place. A lot of the system revolves around the electronic medical record. You have to have your staff hired, you have to have the facility and the supplies, and then you have to have a business plan form that is, we're finding more and more is driven by us as opposed to by them. If we're going to just sell them something, if we're going to sell them the site, the model, and everything, we can just plug them in and make it go. But if we are business partners of profit sharing, we're realizing that it's requiring us to drive it a lot more than we anticipated. We can't just have a motivated person plug them in, give them a plan, have it work. I think because they're not physician salesmen, I think so. I think that's the issue there. A lot of people that have come into it appear motivated and eager, but when it really comes down to it, when you're in the grind of patient acquisition in particular, the physicians get kind of dismayed. And I think part of it's just because of how much they've paid to get their education and everything. They're thinking, oh my gosh, I'm making $2,500 a month right now. Like, this is not right, So, yeah. Does that answer your question?
Yeah. I'm just curious that on scaling this business beyond your pre-physician group, if you're, what is the pitch to number 4, number 5? How do you see the community? Or what do you supply as a system, as a brand for the new physician? And then is that relationship profit sharing driven, or are they an employee of the company?
So what we've done so far, so we've actually got our 4th physician coming on in next year sometime. And so what we're doing is we're supplying the facility, the staff, the marketing, and they are paid based on how many patients that they have enrolled. And so we have a minimum salary for them that goes up based on how many patients they have. They have no ownership in the company, but they have a very comfortable salary once they're busy. So we're trying to keep them motivated to at least engage in the network marketing side, going to chamber events, maybe joining a BNI chapter, joining a service group, and doing what they can that doesn't involve active pitching. And then they make more as their panel grows. So yeah, we're supplying all the system, and we just plug in the doctor.
How many patients is a full panel? What's a round number?
600 to 700.
Okay.
Yeah, 600 to 700. Yeah, and then once they reach that point, the anticipation is that they'll be having a salary similar to other primary care physicians in the area. I will say that the work as a primary care physician in this model is immensely more gratifying. You're not churning through so many patients an hour. You have wonderful relationships with your patients. There's an hour-long established care visit, and all your follow-ups are 30 minutes. And so you have time to really practice medicine and really get to know people. And so if you have a passionate doctor who loves taking care of people, voila, they're happy.
I guess what I'm hearing a couple things. One is, all the doctors that I know that are friends, their enjoyment is taking care of people.
Right.
Their enjoyment isn't out recruiting business.
Right.
The skill for people that are good at that, they don't need to be a doctor.
Yeah.
So, but I'm hearing you're wanting doctors to go out and recruit.
Well, maybe I've got too much of it in because the early doctors, we put a lot of force on. Right now we're wanting them to be present in the community, and maybe even now we're asking too much.
I don't know, I assume you have a business plan in writing, not in your head.
Yes.
Where you are and where you're going.
Yes.
That's a picture to show somebody, here's what we need in recruitment. You got great ideas today on where to go recruit for that person. The concern I would have is, can you take on number of new clients at one time?
It's a good question, and it depends on where the doctor is in their cycle. So our goal moving forward would be able to bring on 25 to 30 new patients a month for each new physician. And that's very doable. Now, if you have a larger business, let's say you get one that's above that 50, you're going to combine it with a partially self-funded plan or something. If you bring on 100 patients at once, it's going to be a lot. We can do it, but you won't want to bring on multiple of those businesses at once by any stretch. Early on, there's 8 hours in the day. You probably wouldn't want more than 3 or 4 new patients a day in that early process because there's going to be a lot of visits early on.
Well, they've got to have a good relationship with you. It's that first meeting and what you're providing and them understanding that, because they had a bad experience and you've lost.
Right.
They're going to tell their friends it was not a good experience.
Right. And when you've got a big group, you kind of triage those, bringing in first that have active medical conditions and then bring on the rest.
Go ahead.
The assumption is you make these connections through businesses and business owners for the large groups of people. I'm thinking direct to consumer. I wouldn't know how to sit down and look at what I have currently and then compare it to the alternative of going with what you have. I wouldn't know how to do that. I'd look at the cost and then I'd have to figure out what's available to me from my employers, and it becomes confusing. And is there a way that you could build an online education portal where I could go and learn through videos of how to analyze what I have now, how to analyze that against what you offer? Then I could as a consumer, make my own decision if that's the route I want to go. Then if you have that video library of content where you taught me how to make that decision, that's infinitely scalable. You don't have to have direct. So then you can tell a physician, we have an infinitely scalable educational resource online. We will plug you into it, and the patients will come through social media targeting and educating the consumer instead of having to make all of these direct connections in local markets all over. It seems like that might be easier.
That sounds really good. That combined with the online enrollment
That's the
process.
thing. I don't know how to go about deciding if I want to do
Right.
the program or not.
Because right now we've been giving people pieces of paper, and you're right. We need to.
You can have a full-time director of sales marketing that is also a licensed insurance agent, and that person can subsidize their income by selling the high deductible plan that is the piece that belongs with your piece.
Right.
And so you can probably get somebody for 50 cents on the dollar and let them make commissions on that other piece, and you're off and running.
Right.
Yeah.
No, yeah, absolutely.
Well, there's one thing that, I think kind of glares for most people when you say high deductible plan. What happens when you do have the heart attack or you need the hospital thing? Is there anybody from Midmo or Arvis that's here? The reason why I ask that is because with free market physician, you say, hey, it's $70 a month for service, but it's $30 a month to go into an HSA, a health savings account, which is like a health savings Roth IRA, where it's specifically designed to bridge that gap for a high deductible plan. So then you have a solution for families, right, that might have kids or might have bigger issues. They have the resources and funds for that. Then when you talk to larger companies or businesses that are worried about how do I analyze this because this is covering the group in that risk, you're able to partner with like an Arvest or a Midmo or somebody that can come in and help them set that up too. So that way you're attacking both sides of the gap. Right? Or SMB or Midmo or, sorry,
Awesome.
I'm new to the area.
It sounds like there's a lot of excitement, and I know there's a lot more questions that can be had, but we do need to move on to our next presenter. We want to be time sensitive for everyone, and so we want to let's give Dr. Joseph Shepherd a big hand. I want to encourage you